Good morning, everyone, and welcome to today's webinar hosted by PYA, 2023 Medicare Physician Fee Schedule Proposed Rule, Part 1. PYA is happy to present today's webinar on this important topic. During the webinar, you may post any questions for our presenters in the question pane of the control panel. We will respond to your questions directly by email following the webinar. For your convenience, we have posted a copy of the slides in the handouts section of the GoToWebinar window. Later today, you'll receive an email with a link to the recording of the webinar and the slides. With that, I would like to introduce Martie Ross, Consulting Principal, and Kathy Reep, Consulting Senior Manager at PYA.
Thank you, Laura. Good morning, everyone. Welcome to a Thursday edition of Healthcare Regulatory Roundup, our first of three addressing the 2023 Medicare Physician Fee Schedule Proposed Rule. Typically, this is the last of the proposed rules we receive on an annual basis from CMS, but for some reason, hospital outpatient ASC was the caboose this year from CMS. But this rule, which weighs in at 2,066 pages in the recently released Federal Register Public Inspection version, will be published formally in the Federal Register on July 26th. The rule itself may be 2,000 pages, but that's only part of the story because at the same time CMS releases the formal rule, it also releases the supporting documentation. There are 24 separate files, and you'll see on the page here the link to which you can access the supporting documentation. This includes, for example, what we refer to as Addendum B, which is the CPT by CPT listing of the assigned WRVUs, PE RVUs, and malpractice RVUs for each and every code, because you use those RVUs then to determine what the reimbursement will be for each of those listed codes. The complete telehealth services list is included there. The practice expense detail, you name it, it's all 24 separate files to access. Comments to this proposed rule will be due September 7th, so you have 2 days after Labor Day to complete your comments and submit them. As you know, we vigorously encourage you to develop and submit comments. And over this next 3 webinars, because this rule is too big for one webinar, we divided it into 3. We will highlight a number of topics on which we would encourage you to develop and submit comments to CMS. All done electronically. It's easy peasy to do that. The final rule generally is published somewhere between November and December. Last year, it was a big surprise when it actually showed up on November 1st. We've had years where it showed up the day after Christmas, so we never can specifically detail when the rule will show up. But that's the background. So let's talk about what we're going to discuss today. Our agenda for this part 1 will include a discussion of the conversion factor, what CMS is the latest on appropriate use criteria, telehealth, virtual services, the request for information regarding underutilized high-value services, and finally, we'll wrap up with a discussion of the extensive revisions to the Medicare Shared Savings Program. In fact, I had to do the math. The section in the proposed rule that addresses the Medicare Shared Savings Program comprises 21% of the total pages of the rule. I guess I had too much time on my hands last night to figure that one out, but it is certainly an extensive part of this rule. So with further ado, I'm going to turn this over to Kathy to discuss our friend, the conversion factor.
Let's talk money.
Mm-hmm.
When we look at the conversion factor, and it actually is called the conversion factor, that is your base rate in terms of the dollar amount that is applied to any particular service under the physician fee schedule. There are three essential components that are each addressed by the conversion factor. You have to look at a relative value unit for each component. So you have work, which is the actual what does it go into in order for a physician to provide that particular service. The practice expense, that is the overhead, the physical plant where the physician is providing services, office expense, etc. And then finally, malpractice expense, which is easily, I mean, it explains itself. Remember that if a service is being provided in a facility setting and a service is being paid for the physician's rate, he would not be paid practice expense because that is incurred by the facility, the clinic, etc. So, but in most services provided in an office setting, you've got work, practice expense, and malpractice expense. Now I'm going to jump on the slide down to the bottom where it says the geographic adjustment factor. That's the GPC, the Geographic Practice Cost Indice. And for each of your relative value units, practice, expense, work, and malpractice, you're going to have a GPC that is going to be multiplied by each one, all of that added together, multiplied by a conversion factor. Confused you yet? That's why most times, and when you see a physician fee schedule, it is called a physician fee schedule because here is the calculation done for you by CPT code, as opposed to all of the math that is behind actually doing that calculation. But the thing that we're really talking about today then, and is having some major impact on the physicians is the fact that the conversion factor, what has been proposed for 2023, essentially encompasses about a 4.4% reduction to where we are right now. So the conversion factor itself, there is a cap on overall physician spending. So we're limited as to how much the conversion factor can go up. If all of a sudden you do other changes within the physician fee schedule program, let's say we adjust the weights of the relative value units, then payment goes down, the conversion factor goes down. We've got to maintain budget neutrality. There was also a requirement under the under MACRA that essentially said that between 2020 and 2025, there would be a 0% adjustment to the physician fee schedule amount, to the actual conversion factor. Now, this has been in place, and we keep seeing that Congress sometimes steps in and Congress says, no, wait, we're going to not enforce the law that we just passed, but we'll see what happens this year. Right now, they are saying because of MACRA, no sustainable growth rate of increase to the physician fee schedule. And then any adjustments to the RVUs, as I mentioned, whether they go up or whether they go down, are ultimately going to cause an impact on the overall expenditures to the Medicare Part B program, and we have to maintain budget neutrality. So we're in a situation this year that because of the law, physicians are going to see a significant reduction in their reimbursement. The next slide, Marty.
I always think of it as a pie, right? Congress says this is the size of the pie by statute, and how that pie gets cut up is the RVUs. And so anytime CMS says, ooh, this particular code appears to be misvalued to us, so we're going to increase the RVUs on this particular component of this code, that means the pie is going to get sliced differently. And so the net result
The pie does not get any bigger.
The pie doesn't get any bigger, but that means the conversion factor gets smaller.
Exactly.
And that's nothing CMS can do about this when that shrinks, except stop changing misvalued codes. That's their option. So anyway, sorry, next slide.
No, I think it's great discussion. And I think it's one of those things, again, we've got to remember CMS's hands are going to be tied on this. If all of a sudden we want to say there's an issue with the way the codes have been valued, that they can address. But what we can't do is address the conversion factor absent adjusting something else. And when it's going to take action by Congress to increase the pie.
Right.
Congress is going to have to do that. And we've got a lot of things that's on the congressional plate between now and the end of the year, because not only are we looking at the concern related to increasing the pie under the physician reimbursement, we also know that hospitals are asking for an increase because of the rate that was included in the inpatient rule. And we've got the issue of PAYGO. Where if Congress doesn't act, we're all going to see a 4% reduction in our reimbursement come January, on top of the 2% we're at right now. So just note that we want you to comment on rules, but you also need to be getting some action going in DC as well. A little bit of history about the conversion factor, and you can see on this slide that what is proposed isn't always what happens because Congress intervenes. So beginning back in 2019, we had a payment rate of 3604. They came in 2020 with a rate of 3609. We got a nickel increase. In 2021, they proposed a significant decrease in the rate. And this was again because evaluation and management RVUs were adjusted, add-on codes that for the complexity of care, it was increased a portion of the spending in the pie, so the rate had to go down. But what happened in 2021, rather than that 3226, we wound up with a Consolidated Appropriations Act, December 27th of 2020, which increased the rate or decreased the rate rather than from 3609 to 32 down to about $35. So we got a little bit of a reprieve. And lo and behold, in 2022, they proposed another decrease. We wound up with a decrease, but it was actually a small dollar amount, just about 20 cents, because that protection came through the way of the Protecting Medicare and American Farmers from Sequester Cuts Act. I mean, try and say that 5 times.
There's no acronym.
there is no acronym for that. That's just, I mean, what were they doing? And so now we're looking at 2023 with a proposed rate of 3308. We don't know what ultimately is going to happen in 2023, but either some of the other things that Martie and the subsequent speakers are going to talk about the valuation of the codes is going to have to change, or the rate will stay the same absent action by Congress. So Martie, the actual calculation itself. Next slide.
Roll, please. There we go.
You can see that we are starting with the current rate of the 3461. We can see the adjustment that would have been in place absent that. Oh, here we go again. The Protecting Medicare, excuse me, and American Farmers from Sequester Cuts Act of 33. We've got the statutory 0% update that was required for under MACRA. Then we've got budget neutrality. This is that we've got a limited pie issue, so that we come up with a rate for this year for general physician services. This isn't anesthesia, but for general physician services of the 3308. As we've said before, these adjustments are due to the relative value units for evaluation and management services, and also to addressing some misvalued codes. This, when you go in and you look at increases or changes to the RVUs for services and compare that to the overall increase or decrease an individual specialty will get, you'll see that it tends to be the proceduralists who this year are going to be most significantly impacted. There was an article published recently where I think just about every society or association for various specialties addressed the reductions and just said that it's unsustainable, but it is the proceduralists who are going to have the most significant reduction.
So Kathy, I think this is a study in why commenting is so critical, because none of this should be a surprise. The AMA began its process of reevaluating the evaluation and management codes, the patient visit codes, back in 2017. And it continued to collect data and finally submit its recommendations to CMS. And it intended to present those recommendations in two pieces. The first being sort of the traditional outpatient office visit E&M codes, and then what are referred to as the other E&M codes, which are emergency room, observation, inpatient, critical care. And so I'm gonna go back a page here because you can see it in 2021. The reason you had that huge drop from 3609 to 3226, that was attributable to the reassignment of RVUs to those outpatient E&M codes. And it was purposeful. It was AMA saying we need to increase the value of primary care.
Right.
And the way we're going to accomplish that is
increase. Agree with.
Exactly. And someone was going to pay for it. If you increase primary care, the alternative is either grow the pie or you're going to end up reducing reimbursement for the specialists. And that's what was proposed. Congress stepped in and just simply grew the pie on two occasions. And so that's where we stand today, is no congressional action to increase the pie. And thus, the reason you see the 3% cut at the top, that's simply because that's catching us up from 2021. And then the other 1.55 is that primarily the impact of the other E&M codes and the reevaluation there. So that's the battle lines as they've been drawn. Again, CMS has that control over the 1.55. I guess you could comment saying you shouldn't have revalued the E&M codes. But that 3% is completely out of CMS's hands. That is only.
But as soon as you say you shouldn't have valued those, we've got people on the other side saying you should.
Right.
You should. So it's, again, I pretty much strongly feel this is going nowhere absent Congress taking action.
Yeah, and there's so much else in line, as Kathy noted. I mean, the deep breath you need to be taking right now is you've already, as of July 1, we're back to the full 2% original sequestration. Absent some action, the pay-go associated with the Build Back Better law is going to hit with another 4% sequestration, right? So we're at 6%. And then add this 4.5% cut. So you're going to wake up on January 1st with your reimbursement for services delivered that day and thereafter cut by 10%.
And if you're asking for an increase in the conversion factor on the physician side, recognize that there's also request to Congress for increases in the inpatient side. Both skilled nursing and home health are facing major reductions in their reimbursement to the tune of nearly 5%. They aren't happy. So what's going to ultimately happen? How much money do we have between now and the end of the year to give us a boost for 2023?
Kathy, we need some good news. Why don't you talk about appropriations?
I never get to give good news. Thank you. Folks have heard me talk about appropriate use criteria until you just wanted to say shut up. But I got to give a little bit of background, but then I get to give the good news. The appropriate use criteria requirement was a requirement under PAMA, the Protecting Access to Medicare Act of 2014. PAMA is also the vehicle that gave us the lab reporting rule, where we had to report our commercial rates to CMS in order for them to ultimately change the lab fee schedule methodology. But under the appropriate use criteria, this was applicable to advanced diagnostic imaging, your MRIs and such. And it required that the ordering physician consult a clinical decision support mechanism, or a CDSM, prior to ordering the test. And then the CDSM, there were several that were reviewed and made available to your primary care physician or the ordering physician. The CDSM would say, based upon the clinical situation of that patient, whether or not the service that you are ordering is appropriate, or not applicable. Not applicable meaning that I'm in an area where there isn't the bandwidth to actually be able to go in and search at CDSM. Hospitals and physicians have been struggling with this. Not only the physician who had to search the CDSM, but then he had to report what he found on his order, and hospitals and the radiologists were required to report what CDSM was reviewed by the ordering practitioner, and did it say that this test is appropriate or not appropriate? And this has been a nightmare for providers. It has just been very, very difficult to do. And this was to be done in all situations other than emergency situations. And I mean, it was very burdensome. But we are in this period right now where it was a test period where we were to report, but I don't think we're getting great reporting come through because of the complexity of this. But CMS always addresses appropriate use criteria in the physician rule. So go in, look under, just do that real quick search on appropriate use criteria or AUC. There's nothing there. So we're thinking like, okay, they're moving forward with the penalty situation on this. No, same day that the physician rule came out, CMS went and they posted on their webpage the page that is dedicated to appropriate use criteria and explains what you need to do and gives you the links to all the CDSMs. They put this big banner, and the banner says that the payment penalty phase will not begin January 1, 2023, even if the PHE for COVID-19 ends in 2022. Until further notice, the educational operations testing period will continue. CMS is unable to forecast when the payment penalty phase will begin. I think this can be translated into CMS wants Congress to make this go away. CMS can't make it go away, but Congress can. And I think that is what they're pushing for, because they recognize the whole intent behind this was to identify those ordering physicians who are ordering tests that weren't appropriate, but they put all the burden on the rendering provider and the facility where the test was being done. So this is good news. It doesn't say don't report. It just says if you don't report, we're not going to penalize you.
And we may never even get around to it, right? So that's our good news. It's only, well, it's not going to go downhill from here, but let's talk about telehealth and what CMS has done with the telehealth rules. And unfortunately, to describe what CMS is doing in the proposed rule, we have to back up a bit and sort of provide some context on where we have traveled over the last 2.5 years with telehealth. In fact, let's go back a little bit further and talk about the provision in the Social Security Act that creates Medicare coverage for services delivered via telehealth, because the presumption in the Social Security Act is a service must be face-to-face, patient to provider, to be reimbursable on the fee schedule. And when Section 1834M was added to the Social Security Act, it created very, very specific criteria that must be satisfied for a service that is delivered via telehealth to be reimbursable. Specifically, it created 5 requirements that each service must meet. First, geographic. The patient must reside in a rural area. There is no telehealth benefit for those residing in urban areas under the Social Security Act. Number 2, location. The patient at the time that the service is delivered via telehealth must be physically present at a healthcare facility as opposed to being in their home. CMS created a facility fee that can be charged then by the originating site. Originating site is where the patient is present. Distant site is where the provider is present in telehealth. Third requirement is the service. Congress charged CMS with developing a comprehensive list by CPT code or HCPCS code of those services that are reimbursable as telehealth. And CMS created this concept of Category 1 and Category 2. Category 1 codes that they've identified are those that are in effect no different if offered face-to-face versus via telehealth. So our sort of traditional E&M codes have been recognized as reimbursable as telehealth under Category 1. Category 2 codes are those that yet the service differs when delivered via telehealth, but there is substantial clinical evidence demonstrating the efficacy of delivering that service via telehealth. Those are Category 2 codes. So pre-pandemic, March 15th of 2020, we had a list of 100 CPT/HCPCS codes that were potentially reimbursable as telehealth services. Fourth requirement is the provider requirement. And in fact, what all this says is that therapists cannot deliver services via telehealth. But these are the category of providers that can independently bill under the fee schedule who could bill telehealth services. And finally, the technology requirement that to deliver telehealth services, it must be a telecommunications technology with both audio and video capabilities permitting real-time interactive communication. There's a little store and board exception that applies, but it's very, very narrow. So usually you had to have a connection like we have right now over Zoom. Of course, Zoom didn't exist back in 2005 when we created these rules, but that was a requirement to have that real-time communication. Not surprisingly, with this many requirements in place, telehealth pre-pandemic was a little teeny percentage of what was reimbursed on the Medicare physician fee schedule. Now, Congress, appreciating the value of telehealth, beginning in 2019, started expanding out the coverage for telehealth services by making exceptions to those requirements. So we had telestroke coverage. So if you were using telehealth for purposes of diagnosing, evaluating, or treating symptoms of acute stroke, we got rid of the geographic and location restrictions. Similar provision for substance use disorder and ESRD, managing a patient receiving ESRD services through home dialysis. So we were creating these narrow exceptions that would allow for telehealth in an urban setting in the patient's home. Also, beginning in 2020, Medicare Advantage plans could create benefit packages that waived the geographic and location restrictions. Now, we never really saw this develop up because we know what else happened in 2020, but we had that opportunity for MA plans to provide broader coverage. And then within the Medicare Shared Savings Program and other CMMI initiatives, if they were risk-based alternative payment models, CMS was also granting exceptions per congressional authorization to the telehealth requirements. So that's where things stood back on March 15th of 2020. And then we had a pandemic. And through a series of legislative and regulatory actions, we ballooned out the coverage for telehealth services. So at the end of February, Congress passes legislation which authorizes the Secretary to waive the geographic and location requirements across the board for the duration of the public health emergency, and then subsequently Congress gave the Secretary the authority to waive the other 3 requirements as well as appropriate. So through a series of interim final rules, CMS both implemented the waiver of the geographic and location restrictions, and gave us direction on how to submit claims, gave us directions on what payment would look like, and then through 2020 continued to publish interim final rules that again expanded out the scope of telehealth services. Specifically, a major expansion in the number of covered services. So the list went from about 100, well, it was 100 codes before the pandemic. It's up at about 250 right now under the action CMS has taken over the last 2 years. It eliminated a number of frequency requirements, the limitations on how often you could use telehealth services to provide a certain level of care for patients in certain settings. It also created the use of telehealth for what would otherwise have been a required face-to-face visit or a direct supervision requirement within sort of the incident to and teaching rules as well. CMS also took action to change the provider restriction, most importantly, permitting the therapist and the speech language pathologist to deliver certain services via telehealth. Important for primary care in particular was the creation of these audio only E&M services. So CMS never waived the audio visual requirement. It instead created a particular set of codes that could be delivered via audio only, a pretty clever way around the statutory requirement. And those CPT codes, you see the numbers listed there, would allow telephonic only to be reimbursed at the specified levels when those codes were introduced. Importantly, to encourage the use of telehealth, CMS changed its payment policy. So pre-pandemic, if you delivered a service via telehealth, you as the provider at the distant site, even if you were in a physician practice, you were reimbursed for that service at the facility rate, meaning the lower rate. Ms. Kathy explained when we were talking about the conversion factor, if a service is delivered in a hospital outpatient setting, the reimbursement for the physician is lowered because you extract out the RVUs assigned to practice expense. And CMS's reasoning historically had been, well, it's a heck of a lot cheaper to turn the computer on and just talk to somebody as opposed to having all the other practice expense associated with it. You know, we can all discuss the merits of that position, and we will in comment as we talk about this. But CMS determined that for the duration of the pandemic, because we want to encourage physicians to deliver services via telehealth, then we are actually going to pay at the higher non-facility rate. So if you've been submitting your claims for telehealth services as a physician practice, you've been reimbursed the same way as if it was a face-to-face service. There's been no difference. So that's where we were. We also had some guidance from Office of Civil Rights with regard to HIPAA privacy and security concerns about the type of technology utilized. OCR said, we're not going to worry about this. We're going to issue a notice of enforcement discretion. Go ahead and use Zoom. Go ahead and use Teams. Don't have to worry about all the security issues for the duration of the PHE. We had the Office of Inspector General issue another notice of enforcement discretion saying, it's okay to waive copays and deductibles on both telehealth services and virtual services. We're not going to pursue any action under the prohibition on patient inducements if you elect to waive the copay and deductible. It's like actually everyone got on the same page, singing from the same sheet of music, that we were going to do everything we could to encourage the utilization of telehealth services because we identified it as critical to accessing care during the PHE. And now what happens with the end of the PHE? Well, we've been answering that question in little bits and pieces, okay? And that first bit and piece was a change that was included in the Consolidated Appropriations Act, that same wonderful piece of legislation that protected the conversion factor for 2021. Also, amended Section 1834M with regard to the geographic and location restrictions. And it said to the extent that you are delivering services that are for the diagnosis, evaluation, and treatment of a mental health disorder, we will waive the geographic and location restrictions. However, we still think it's important that there be an initial face-to-face visit. So we only want you to be able to deliver the services via telehealth if there is a face-to-face visit with the same practitioner or same provider in the practice that occurs within 6 months prior to the initiation of telehealth services for that purpose. And also, Congress wanted there to be an annual check-in face-to-face, again, to protect the quality of services being delivered. CMS last year in this physician fee schedule process developed the actual implementation regulations around this, and they created an exception to the 12-month rule, saying that if you determine that it's not appropriate for the patient to come to visit face-to-face, that it would be detrimental for the patient to meet face-to-face, you can waive that requirement. Because if you decide this relationship's working great over the screen and we don't need the face-to-face, the physician can waive it. Also, CMS permitted use of audio only for the delivery of these services, so long as, again, the physician says that it's appropriate to do audio only, and that the physician also documents that they have the capability of delivering the service versus audio or visual. So all of this is set up, ready to go. at the end of the PHE, because of course the PHE rules are even broader, right? But we've created this entire statutory and regulatory scheme to expand telehealth coverage for these diagnosis, evaluation, and treatment of mental health disorders. All of that's ready to go, thanks to that original congressional action and the regulatory follow-up work that CMS has done last year. And then the next piece of the post-PHE fill-in was part of the Consolidated Appropriations Act of 2022, not to be confused with 2021. 22 is much shorter. But this was passed on the Ides of March 15th of 2022. And this was the telehealth flexibility extensions, where Congress came in and said, for 151 days after the end of the PHE, we will continue these waivers of certain requirements under Section 1834M, most importantly, the geographic and location restrictions, but also will continue to allow therapists and speech pathologists to deliver services via telehealth. We'll continue those unique audio-only codes post-pandemic for 151 days. We'll continue to let FQHCs and RHCs bill for telehealth services for that 151 days. And we'll have some other more limited requirements we'll permit to go forward. Why only 151 days? Well, it's all about the price tag. That if we were to eliminate the geographic and location restrictions and permanently expand telehealth, that carries with it a very hefty price tag. And no one's willing to swallow that because, again, this is a entitlement program and PAYGO kicks in. So anytime that you would increase spending on an entitlement program, you have to either raise taxes or cut other spending to pay for it. And Congress has enough on its hands with the PAYGO issues associated with the Build Back Better law, i.e. the 4%, right, Kathy? 4% sequestration that'll kick in at January 1st, but they don't want to add this to the mix as well. So 151 days is what they were willing to swallow going forward. So for 5 months, effectively, post-PHE, we will continue with telehealth coverage. It's intended to be a step-down process. Where's the PHE? Very, very quietly. I mean, very, very quietly. The Secretary last Friday signed the extension of the public health emergency. We were all freaking out, thinking it's 4 o'clock on Friday and nothing's happened yet. There's no extension to the PHE. They've broken their promise to give us 60 days notice, but very, very quietly. The signature appeared on the magic document. So as we stand today, the PHE remains into effect through mid-October. Again, administration has said that they'll give us 60 days notice. So we'll look up in August and see if there's any other action taken. But at this point, we are still in this cycle of every 3 months renewing the PHE. So finally, kind of exhausted after all that, this is where we find ourselves in the proposed rule for 2023. This is CMS now squaring up everything Congress has done, preparing itself for how we intend to go forward. The first thing is what they did with the Medicare telehealth services list. Remember, went from 100 to 250 codes, and now the question is, where is it going to stand post-PHE? And CMS last year created this thing called Category 3 codes. And Category 3 codes are those codes that were on the expansion list that CMS says, you know, we think with a little more evidence that these are probably things that would become Category 2 codes. So we want to give folks some additional time to develop the evidence base in support of these particular services. And so Category 3 will remain on the telehealth services list through 12/31 of 23. What CMS did in the proposed rule for 2023 is expand out that Category 3 list, sorry. What you see on the page that you can't read because it's so small are the list of codes that will fall off the telehealth list on day 152 post-PHE. So these are the expansion codes that were not included in Category 3, thus they go off the list effective day 152. And the ones to pay attention to here are all of the initial facility visits. So initial hospital care, initial skilled nursing facility care, they want that to go back to being face-to-face services. So that's the most extensive of those that are going off the list. Also going off the list is the telephone E&M visit codes, because CMS says they don't have the authority post-pandemic to continue those. They were specifically extended in the telehealth waiver, the March 15th legislation. CMS says they have to go off the list at day 152. So this is, again, if you're looking to lobby Congress, this may be something worth lobbying on, is to continue those telephone only codes, because they become so critical to improving communication between physician practices and their offices. CMS also, in the proposed rule, added a little set of codes to category 1, and those are the GXXX1 and 2 and 3 codes, which are now prolonged inpatient nursing facility and home and residence codes. Those are new codes that were created as part of the reset of the other E&M codes. You know, next week, no, 2 weeks from yesterday, Valerie Rock from our office is going to walk you through the E&M changes that are finalized, well, not finalized, they're proposed. They're from the AMA. CMS has adopted them here in the proposed rule. So she'll go through those in detail, including these new GXXX codes. But know that they are now included as category 3 permanently on the telehealth list. So it's a lot of words. It's a lot of words in the proposed rule. It's a lot of charts. But what it all comes down to is CMS is squared up its interim final rules, what it has done through regulation, with what Congress did in the Telehealth Flexibilities Act, so that where we are today, what things look like today, are going to look just the same through day 151 post-PHE. It's day 152 that things change. Remember all those rules we have with regard to the delivery of services for mental health disorders? Those are all going to kick in day 151. So that's when you have the 6-month face-to-face requirement, the documentation of why you're using audio only. All of that kicks in day 152. So again, sort of a long way through these rules, appreciating that there's just a lot of complexity in how this has handled itself PHE. The bad news, and get ready to comment, is what they're doing with claim submission and payment. What we've been doing through the PHE, and what we'll continue to do for 151 days post PHE, is that we have submitted these claims for telehealth with modifier 95. You continue to use the place of service as what would have been had it been a face-to-face visit, and you just add modifier 95. And you're going to continue to be paid at the non-facility rate. But on day 152, we're done with modifier 95. You're either going to use place of service code 2, which is telehealth provided outside the patient's home, or place of service 10, which is provided in the patient's home. That's only intended for those exceptions: mental health disorders, telestroke, ESRD, substance use disorder. That's when you can use the 10 code, because you're permitted to be reimbursed for those services when they're delivered in the patient's home, right? So you're going to go back to bye-bye 95, bye-bye using 11 or 22. Now you're going to stop using modifier 95, and you're going to go back to using 2 or 10 as the place of service codes. And the really bad news is you're now going to be paid at the lower facility rate. And there's the quote: "We believe that the facility payment amount best reflects the practice expense, both direct and indirect, involved in furnishing services telehealth." I'm sure you have a lot to say to CMS on that point, because I have a hard time understanding how the practice expense, all of the background work you do to turn on the screen and talk to the patient, I can't imagine how that is significantly less than having the patient walk through the door. And that certainly this is going to be the wall we hit with delivering telehealth services. Remember, this includes those new behavioral health codes, right? We're going to be able to expand telehealth by delivering it via expand behavioral health services by offering them telehealth, but we're going to pay you less. We're not going to recognize your practice expense. So, you know, fingers on the keyboard. This is a great opportunity to comment, because otherwise I think we're going to see a lot of significant decline of telehealth when we just didn't need to do it. CMS also promises that it will issue other sub-regulatory guidance as necessary through the end of the PHE to ensure a smooth transition overward. We all love sub-regulatory guidance, don't we? Because we don't get a chance to comment on it. And so again, this would be your opportunity to, if there are any specific issues you have concerned about what happens post PHE, please bring this to CMS's attention now in the comment process so we can actually have them think through the answer as opposed to the sub-regulatory guidance.
Martie,
So,
let me ask a question. From the comment perspective, we've got practices that are going to be commenting saying that we really need to include the facility as if it was provided within the office, that payment level. I have a feeling that if they don't, then we're going to have a lot less telehealth being provided, and might be a good idea to encourage those patients with whom you are doing actual telehealth services to also comment. I hate to say it, but sometimes it's the patient, it's the consumer who has more swing with this.
absolutely. That's a great point.
It might be if you are providing these services, you want to continue, but you want to be paid appropriately. Get your patients to weigh in.
Absolutely. Absolutely. So I think this area is just a great opportunity for us to try and impact the policy as it goes forward. The last thing I'm going to say about telehealth, and again, another opportunity for comment, concerns direct supervision. I think this has been like one of the great advancements during the PHE, is that for incident to services, direct supervision could be delivered virtually, as opposed to having to be, take a deep breath, present in the same suite of offices immediately available to provide assistance, right? That's the tagline for incident to. Instead, we've been able, like, you've been available on, this has become the basis for providing direct supervision. CMS says, yeah, we're done with that. As of December 31st of the year in which the PHE ends, you have to go back to the physical presence requirement. CMS says that we don't want to extend it beyond December 31st. So if the PHE ends on October whatever 17th, I don't remember, then as of 1/1/23, we go back to in-person supervision. They continue to want to seek information on whether virtual supervision is adequate and whether we should make it permanently. If they're seeking information, again, great opportunity to comment. Talk about your experience and how you've been able to deliver these incident to services under direct supervision, and that virtual has been adequate. If you're in a teaching setting, how the use of virtual supervision has been adequate for purposes of supervision of those graduate students. But they want stories. They want you to tell them it's worked. There's been no questions. We haven't had any incidents. They need to hear that over and over again, because this could be a great advancement in the use of virtual services appropriately. Enough. There we go. Virtual services is our next topic. So enough on telehealth. Let's talk about virtual services. What's the difference between telehealth and virtual services? 1834M doesn't apply to virtual services. CMS back in, I think it's 2019, I think that's when they did this, they made this very hard distinction between what is a service subject to 1834M and what is not. And what they said is this category of virtual services do not have an equivalent face-to-face service. They are by their very nature facilitated by some sorts of communication technology. And so when 1834M was created, it was only focusing on telehealth as a substitute to face-to-face, and that virtual services are not therefore subject to 1834M. So we can deliver these services to everybody without regard to rural, urban, or any of those other requirements. So this has been an area of growth since CMS first introduced transitional care management in 2013. We've added chronic care management, principal care management, we've added remote patient monitoring, we've added internet consults. All of that has come in under this banner of virtual services. So what do we know from the proposed rule? Even though we continue to beg CMS for concrete guidance around these core virtual services, transitional care management, chronic care management, and most recently remote physiologic monitoring, we've had there's nothing. There's no further new guidance in the rule on any of those topics. The only thing of note, and this is one of those things that make you crazy about the proposed rule, is when you go into Addendum B, which is the listing of all the assigned RVUs for every CPT code, and you look up CPT 99454, which is the monthly transmission of data code for purposes of remote physiologic monitoring, CMS adjusted the practice expense. It's a practice expense only code. There's no work RVUs assigned to it. They once again, a second time in a row, they've adjusted those RVUs down, which is resulting in a 12% cut in the monthly monitoring fee. No explanation. I mean, I've been digging through it, trying to figure out what exactly has happened. I'm not there yet. It must be there somewhere, but I haven't found it. But for a service they're trying to encourage, they have instead, once again, reduced the reimbursement. And we can go into about a 3-hour webinar on all the issues of how the practice expenses were assigned to these codes. They are based on very old surveys of cardiologists and how they monitor heart failure patients, that they don't have any real connection to how RPM services are in fact being delivered. But again, a whole nother topic and a great opportunity for comment. Anyway, CMS did create a new set of codes for remote therapeutic monitoring. Remember, this was introduced last year in the physician fee schedule. It was like 2 pages of Federal Register guidance, and no one could quite figure out what they were talking about. And they talked about these therapeutic codes, but they have now created a new set of codes. Their intention is to permit this service to be delivered both by clinical staff under the supervision of a physician or non-physician practitioner, as well as by therapists. So they've cleaned up the code set in that regard. They've also created new reimbursement for something called cognitive behavioral therapy. One of the confusing aspects of remote therapeutic monitoring, it is effectively limited to monitoring musculoskeletal conditions and respiratory conditions, because that's the data transmission codes are limited to those 2 conditions. CMS is proposing to add another data transmission code, which would permit the monitoring for purposes of cognitive behavioral therapy. But rather than assign the WRVUs, assign the practice expense to it, they decided to permit that to be accomplished by contractor set pricing. So that will be interesting to watch during that period of time. And finally, CMS is creating a new animal called chronic pain management, which this is a bundle of monthly services. In fact, let's just jump up there. One more. There we go. I'm sorry, we're running a little short on time, so I'm skipping through slides, but you have the slides so you can read all the content. But the CPM is a monthly bundle of chronic pain management and treatment services. You see here the description of the bundle. You have to provide this service. You have to have a chronic pain diagnosis. You have to perform an initial face-to-face visit of a minimum of 30 minutes to address the patient's pain condition. And then you must secure verbal consent from the patient. And you see there the reimbursement associated with these codes, pretty comparable to principal care management going forward. CMS has lots and lots of questions that they want the industry to respond to regarding the creation of this new benefit of chronic pain management. We think we'll allow 2 practitioners. We want a primary care physician and a specialist to be able to build this code during the same month for a patient. Right now, they're allowing this code to be billed along with other care management codes because this is intended to be a very focused, unique service. They want you to comment on whether you think certain components can be performed by clinical staff under general supervision. As the code reads today in the proposed rule, I don't think that is contemplated. How often should you be allowed? How many minutes of service should be reimbursable? Or do we need to kick in a medically unnecessary edit code on top of this? And can we permit that initial visit to be performed telehealth? So if you are working with patients with pain, it is certainly worth a read in the proposed rule and comment how you believe this code should be appropriately developed to help you better manage these patients. Related to all of this is an RFI, which I want to call your attention to, which is the potentially underutilized codes. Here's the language from the proposed rule. CMS is concerned that there are a lot of high-value services, preventative services, the virtual services that are not being utilized at the levels they had anticipated. And they want to understand what's going on. What are the barriers to providers delivering these services? What are the barriers to patients receiving and consenting to these services? why are there inequity issues here that we need to address and the like. So I think this is the golden opportunity for comment. You see here just a few of the thoughts I've had regarding these underutilized services, beginning with the need to reevaluate the practice expense RVUs, i.e. the reimbursement that are associated with these, eliminating the established patient requirements, the verbal consent requirements, all of these additional requirements CMS globbed on to these virtual services for purposes of making sure there was quality there. I think the test is, have they really made sense? And I think the need for definitive guidance just cannot be ignored. I went through and found 3 different instances in 3 separate proposed rules where CMS promised that they would be issuing additional guidance on remote patient monitoring. It still hasn't showed up. We still are inundated with questions on a regular basis on how these codes work in practice. And I think it's time CMS provide us with guidance, and that I think is a critical topic for commentary in response to this particular RFI. For the last 4 minutes of today's assigned time, let's review the changes to the Medicare Shared Savings Program. And this is the equity provision in the physician fee schedule. You know, Kathy and I have been talking about how this is a unique set of proposed rules this year because all of them are drilling down on this CMS commitment to health equity and advancing health equity through both regulation and reimbursement. The Medicare Shared Savings Program, which of course is the bright star in CMS's constellation of alternative payment models, was seen now by CMS as a real vehicle for driving its health equity agenda. But appreciation that the program has been languishing, that the changes made to the program in 2019 through the Pathways to Success have in fact sort of stagnated participation in the program, that we've had 2 years of permitted allowing ACOs not to move to downside risk that has sort of held the program together, but real concern about what's going to happen next year as we go forward. So there is a really nice description of the role of alternative payment models in advancing health equity in that they eliminate variation in practice. You know, Kathy was talking about an article she just read in Modern Healthcare, right, Kathy? A study from Deloitte saying that by, say it for me because I'm not going to remember it right.
$1 trillion increase in overall healthcare spending because of disparities.
Yeah.
And unfortunately, they used the term in there that we're biased. And I mean, are we looking at bias in healthcare?
So CMS in the proposed rule says the Mssp is the horse we're going to ride in terms of pursuing a lot of our equity strategies. So we want to make it easier for folks to participate in this program. So, and also on top of that health equity concern, go back to CMS Accountable Care Strategy, which they published as part of the Innovation Center refresh back in October of 2021, where CMS kind of drew the line in the sand and said by 2030, all, as in 100% of all traditional Medicare beneficiaries and most Medicaid beneficiaries are going to be in care relationships that involve accountability for total cost of care, either through advanced primary care models, episodic payment models, or importantly, accountable care organizations. So again, easing the restrictions on the Mssp are intended to be part of that. You see here the 6 critical changes that are made to the Mssp program. Let's review them briefly. Starting with the kind of the sub pathway to success, as we've been calling it, the different road, the road less more traveled probably. You know, since 2019, an ACO that joins the Mssp has had 2 years before they have to assume downside risk. For 2021, 2022, CMS waived those requirements. So they allowed those ACOs that were in one-sided models to continue in those one-sided models for 2 years, but this was the cliff. As we were going into 2023, these ACOs that had not taken downside risk said we either have to go to downside risk or get out of the program. And fearful that we were going to have a whole lot of ACOs leave the program, CMS in the proposed rule says, if you are in one-sided risk during your current performance period, you can continue in one-sided risk through the end of your current performance period. So the end of your current contract on Mssp, you can stay in one-sided risk. And then beginning in 2024, so the next round of applications, an ACO that comes into the program new, that doesn't have experience with downside risk, we're going to allow them to spend 5 years in the program in upside risk only. And in fact, for their next agreement period, we'll allow the first 2 years of that agreement to remain in one-sided risk only. So 7 total years for ACOs to get up to speed, not worrying about having to repay CMS if they exceeded their benchmark. Benchmark methodology. Wow, this is like inside baseball to the nth degree, is all the changes that CMS has proposed to its benchmark methodology. The most important being this accountable care perspective trend, which is intended to adjust a benchmark based on the level of MSSP participation. Because if your historical and regional benchmarks are impacted because there are a lot of folks working on total cost of care in your region, then we're going to make an adjustment based on it. And you can see here the other type of adjustments they've made in terms of prior savings adjustments, how they're changing the application of the HCC increases, how they're addressing the negative regional adjustment. All of that comes into play. The one thing they didn't do, which I'm still trying to figure out, is that they do not propose to change the methodology for looking at historical spend to account for the historically low utilization in 2020. They say that 2021 has sort of brought it back up to normal again as we're looking at the data, so they don't necessarily need to see any change there. I think that's a reason to comment, because I think there's going to be some real messed up stuff when you start looking at the 2020 numbers. Next up is the health equity adjustment that they are offering, that if you are an ACO that serves a high level of underserved population as measured by the number of dual eligibles, as well as the area deprivation index for the geographic area you serve, we are going to make an upward adjustment to your quality performance score. And that in effect will increase your ability to earn shared savings. So rather than trying to make an equity adjustment within each measure, and the issues that creates, we're just going to look at your population and base your health equity adjustment on that. This is very similar to what they're doing in the ACO REACH program. They're bringing it into the MSSP. The advanced investment payments, this is built off a CMMI model from the advanced payment model that was created within a CMMI program. Again, if you are a new ACO, but you have to be a low volume ACO, meaning that your participants only have to account for 35% of the total spend for your attributed beneficiaries. But if you are new and low volume ACO, then you're going to be eligible for advanced payments on your shared savings. That's starting with a $250,000 one-time payment, and then 8 quarterly payments during your first 2 years of participation that are, again, are based on the population you serve. So you're going to get more dollars if you're that higher area deprivation index, that higher number of dual eligibles. Your funds can only be used for certain purposes: to improve infrastructure, and then increase staffing, and then to address those high-risk populations directly. These payments made to you will be recouped from future savings, meaning, but you do not have to repay them if you do not make savings. So there's no back-end whiplash. These are advances on shared savings only. And finally, there's a separate proposal also to the benefit of these small ACOs that would make an adjustment in the minimum savings rate, because we had a lot of young baby ACOs that they save money, but they don't save enough to exceed the minimum savings rate, so they don't actually receive shared savings. CMS is proposing to make an exception so that there are, in effect, first dollar savings shared with these smaller ACOs. Number 5 are changes to the quality measures that we're going to go away from the all or nothing rule that have been adopted back to the sliding scales. That's great news, so that you don't lose your shared savings based on quality scores. There's also an extension of the incentive to use ECQM measurements as well, and then a change in the benchmark methodology, again, to try and bring equity into the program. Last but not least, maybe least, our elimination of a lot of the administrative burdens associated with this program. It's just, sometimes just a lot of ticky-tacky stuff you have to do because you participate in the MSSP. So there's changes on when you have to send beneficiary notices only once now, with a follow-up 6 months later, eliminating that pre-approval of marketing materials, streamlining the whole process for securing the SNF 3-day stay, changing the data use requirements to allow you to function as an organized healthcare arrangement to ensure you have a better savings of data. That also changes the reports as they come into you. So it's a pretty broad rethink and revamp of the MSSP. If you're participating in the program, certainly an opportunity for you all to comment going forward. Encourage and reward CMS for doing something good. If you're one of these
Comment about the things you like. Comment about the things you like.
Exactly, so it doesn't go away. So that's our first run through part 1 of the MSSP, sorry, I'm making up my acronyms, the Medicare Physician Fee Schedule. We have 2 more webinars on this subject, but you don't get Kathy and me. You get much more qualified individuals. Valerie Rock will be handling part 2. Again, that focus on the changes to E&M, as well as the expansion of behavioral health coverage. And then on August 10, Lori Foley, who is our QPP expert, will be addressing the quality payment program. That's the MIPS reporting requirements. Kathy and I will be back with you on August 17th to discuss the OPS rule and the ASC rule. And we know sitting at OMB are the final rules for inpatient, inpatient rehab, inpatient psych, and SNF, and hospice, right? I forgot hospice again.
Hospice, yes.
As those rules come out, we'll be scheduling dates to review those with you and all. The reason we're not doing anything in the next week is because PYA will be sponsoring its summer CPE symposium. 8 CPEs for webinars across 2 days. You can find more information on the website about that. And I only went 6 minutes over. I apologize, everyone, but there's a lot in this rule, a lot to discuss. But thank you for joining us, and we'll see you soon.
Take care.
Thank you. And thanks to our presenters, Martie Ross and Kathy Reep. If PYA can provide assistance with audit, tax, compliance, valuation, or physician services, call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.